Hello, everyone, and welcome to today's webinar, The Changing HPV Testing Landscape and the Impact of Primary Screening. I am Cassie Saltman of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Abbott. To learn more, visit www.molecular.abbott.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We'll answer as many questions as we have time for at the end of the presentation. Also, if you experience any technical issues, you can utilize this Q&A box and we will assist you directly. I'd like to now welcome our speakers, Dr. Marc Steben, President, International Society for STD Research, Co-President, STI and HIV 2025 World Congress Member of the Board, and Chair of Education Committee, International Papillomavirus Society, and Dr. Stefan Riedel, Associate Professor of Pathology, Beth Israel Deaconess Medical Center. Dr. Steben, you may now begin your portion of the presentation.
Thank you. Good day, everyone. Very happy to be with you today. I'm presenting my potential conflict of interest statement for the last 3 years. And just a note before we begin, the use of word women is should be in the larger sense for all people that have cervix. So most of the studies, of course, that we will be presenting have been done on cisgendered women. So we recognize that there are other people with a cervix. So we'll use women to be larger in the larger definition. So I was given learning objectives. I will talk about burden of cervical cancer screening principles, cervical cancer guidelines, the shift from cytology to HPV testing for screening, and the future of HPV testing. So let's start with the burden of cervical cancer. It's interesting to know that this disease that has been known for more than half a century, still one woman will die every 2 minutes. Although now we have the knowledge, we have the tools to prevent and even eliminate this disease, they already exist in terms of vaccine and HPV testing. We have WHO Global Strategy for Cervical Cancer. So WHO gave us 3 objectives in the global strategy. So by 2030, HPV vaccination, 90% of girls should be fully vaccinated by age 15. Screening, 70% of women should be screened with a high performance test by age 35 and again by age 45. And treatment, 90% of women identified with cervical disease should receive appropriate treatment. The incidence is still very high with cervical cancer, and in fact, even with the tools we have, it should continue to increase for a little while before we implement the preventive strategies of vaccination and screening. Cervical cancer is the 4th most common cancer in women worldwide, with 660,000 new cases per year, 350,000 deaths linked to this disease, and 94% of the 350,000 deaths from cervical cancer occurred in low and middle income countries, and a fair proportion of the 6% left for our own low-income population in high-income countries. So prevention of precancerous lesion and cancer is also associated with HPV infection, and it should be considered as a key element of the global health sector strategies against HIV, viral hepatitis, and sexually transmitted infection for the period 2022-2030 adopted by WHO. We know that at this moment, there's a big inequity in terms of distribution of the preventive methods, and we know the shaded areas that are bluer in the top map, and the second one in the red in the lower map. So it's incidence and mortality. We see that the incidence and mortality is concentrated in the low-income countries, and also the access to these preventive sensitive technology is limited by the economy situation of the developing countries. In US, the trends in cervical cancer incidence and mortality is very good. We saw that there's a decrease of at least 50% in cervical cancer incidence and mortality since 1975, but we see that there's a plateauing effect from 2005, and we know that there might be different reasons for that, and we'll come back to the screening criteria in a few slides. So the incidence of cervical cancer is increasing. There's suboptimal participation in screening, in particular less intensive screening because of COVID-19 disruptions. There's lower coverage among young women and suboptimal follow-up after screening. There's also higher prevalence of human papillomavirus due to the evolution of sexual practices and suboptimal coverage of HPV vaccination in some populations. There are also illnesses and treatments that lower immunity that has increased over the years. We know that women living with HIV are 6 times more likely to have cervical cancer than the general population. And because of highly active antiretroviral therapy, people are much less likely to die with HIV, but are living with HIV much longer than before. And the number of Americans that self-classify as immunocompromised increased from 2.7% in 2013 to 6.6% in 2021. So there's a huge increase in immunosuppressive therapy that might increase the risk of cervical cancer. And the number of Americans on Medicaid that have received adalimumab jumped 3.5 times between those same years. So much more immunocompromised people in the population. Let's go to the screening cancer screening principles. So we know that there can be primary prevention with vaccination, and the population targeted by vaccination is not the same as the population targeted for screening. Screening is secondary prevention, so it's to prevent the development of disease, and tertiary prevention has to do preventing the mortality and the death of patient with HPV cervical cancer. So let's talk about the secondary prevention with screening. So WHO defines screening as the presumptive identification of unrecognized disease in an apparently healthy asymptomatic population by means of tests, examination, or other procedure that can be applied rapidly and easily to the target population. A screening program must include all the core components in the screening process, from inviting the target population to accessing effective treatment for individuals diagnosed with this disease. In 1968, Wilson and Junkner presented their principles for appropriation, for having appropriate and timing of screening in the population. So there are 10 principles. So the condition should be an important health problem. There should be an accepted treatment for patient with recognized disease. Facilities for diagnosis and treatment should be available. There should be a recognizable, latent, or early symptomatic stage. These should be suitable tests or examination. The test should be acceptable to the population. The natural history of the condition, including the development from latent to declared disease, should be adequately understood. There should be an agreed policy on whom to treat as patient. The cost of case finding, including diagnosis and treatment of patient diagnosed, should be economically balanced in relation to possible expenditure on medical care as a whole. And the case finding should be a continuing process and not a once-for-all project. So these were the principles in the time where we had cytology, but we have to realize that the availability of nucleic acid amplification technique tests make us revisit these principles. and we can say that there should be a suitable test or examination. There's more and more reluctance to say that cytology is the best test to be used for screening, and the test should be acceptable to the population. I think that women will certainly say yes to a newer test. We know that a certain proportion of the population are not coming to be screened and develop cancer because the test is considered unacceptable to themselves. And finally, the cost of case finding should be economically balanced. And we know with the increase in the population who are protected against high-risk HPV contained in the 3 HPV vaccine we had access in North America, makes it less and less valuable to go with cytology. We have to make a decision to go for a test that is much more appropriate for the population that has been vaccinated. Let's look now at the cervical cancer guidelines. And I think there are some principles very well explained. The IARC in Lyon, part of WHO, have perspective on cervical cancer screening. There's an handbook from IARC, and there's also WHO guideline for screening and treatment of cervical precancer lesions for cervical cancer prevention. It's the second edition, and there are 2 web annexes that are spectacular in terms of content for people to that want to look at the most efficient protocol in their practice. And these are more suitable for low and middle income country, but still the discussion held in the book is certainly helping us in high income country to make a decision. In United States, we've retained, for the sake of this presentation, ACS 2020 guideline, the USPSTF 2018 guideline, and a little discussion with the WHO guideline. So we agree that for ACS, no screening before the age of 25. And for USPSTF, there's still Pap tests every 3 years. WHO does not recommend any type of intervention for person under the age of 25, even for those that are HIV positive. For the population age 25 to 29, HPV test every 5 years is the preferred indication for ACS. HPV PAP co-test every 5 years is acceptable, and PAP test every 3 years is also acceptable. USPSTF recommend PAP tests every 3 years for that population. And WHO, women with HIV should be screened every 3 years starting at age 25 with HPV DNA test. Then we look at the age of 30 to 65. HPV test every 5 years is preferred, with HPV and PAP co-test every 5 years acceptable, and PAP test every 3 years acceptable. So same recommendation are as we've seen for the age of 25 to 29. USPSTF PAP test every 3 years, HPV test every 5 years, or HPV PAP co-test every 5 years. And from the age of 65 and older, no screening if a series of prior tests were normal, and no screening if a series of prior tests were normal and not at high risk for cervical cancer for ACS and USPSTF. But WHO screen every 5 to 10 years starting at age 30 with HPV DNA tests, minimum of 2 lifetime screens with HPV DNA tests by age 35 and 45. And there's interesting development. We know that Scotland and Australia now are proposing for women to be screened until the age of 65, and that there's an exit strategy that will include a HPV test to be given, not to be screened anymore in their lifetime. We see that the cost and benefit of strategies in different regions of the world would differ, but we know that the more tests we're giving, the less effective we are economically. And if we look at like strategy with 2-year liquid-based cytology and 1-year liquid-based cytology, we see the astronomical cost of screening for minimal return on the investment. And we see that even when we go to 3 lifetime HPV tests, we have a pretty good reduction of the cervical cancer risk with minimal cost lifetime for the patient. So we're looking at strategy now that will go less frequently, also to minimize the cost on infrastructure, medical infrastructure that are under pressure in many countries in the world. Let's talk about the shift from cytology to HPV testing for screening. So we see what happens in the lifetime of a woman that acquires HPV. So there's the infection, there can be clearance. So the virus is still there, but not detectable. She goes to HPV infection. There will be progression, and it can be regression also from pre-cancer. And then there will be invasion and the development of cancer. So, of course, we could start very rapidly with HPV nucleic acid test and see if a person is infected. But we know there's a large time between the infection acquired and the development of a significant lesion. So we have to be careful. Too frequent to follow at stage where no deaths is averted for infection because infection is being controlled. So we don't advocate starting HPV testing before the age of 25 or 30, depending on the country and the technology that's being used. Cytology was certainly the strategy to go with Papa Nicolaou making the discovery in the 50s of the use of cytology to identify disease that could be treated. So most frequent lesions that are discovered by cytology are benign abnormalities, so ascus and LCIL. They still demand a high level of follow-up without necessarily decreasing deaths. So cytology might not have to place it in the screening program. Visual inspection with acetic acid. So this is the preferred technique in low-income country, but we know it has low sensitivity and low specificity. And with the cost of nucleic acid amplification tests going down, it is recommended by WHO to go with HPV nucleic acid test. And there are other tests that are very specific, but they're also quite expensive and labor intense. So P16, Chi67, dual stain, methylation, all these assays would be kept for triage in a test, diagnose, and treat strategy. And big surprise, there's no perfect test. So a laboratory test that is 100% precise, 100% exact, 100% of time does not exist. So we have to work with imperfect laboratory tests. Still, nucleic acid tests are pretty much better than cytology. So we have to know the strengths of the tests we're using, but most important, their weaknesses. And with cytology, a study that was done from my colleagues in Montreal at McGill University, we see that cytology was very good in the time where there was a lot of disease compared to now where the disease has come rare. And we see that 50 to 60% of women diagnosed with cervical cancer had no previous screening or the screening was done too long ago. So few percent, it's rapid evolution of cancer, so mainly HPV 16 and 18, a little bit HPV 45, rapid evolution of cancer, treatment failure, about 5%, inadequate follow-up either from the healthcare practitioner or from the women represent 8 to 15% of diagnosis of cervical cancer, but 20 to 25% are from false negative on cytology. And we know that 2/3 of cytology that are not producing a good result will be from sampling, 1/3 from detection by the lab technician under the microscope. So cytology has a limited value. And if we look at the different strategies, so the cumulative detection of invasive cervical cancer, so this comes from 4 randomized trials of cervical cancer screening in 4 European countries. And we see the big difference in time between those women that receive HPV screening compared to HPV cytology, blue for HPV screening and red for cytology. And this difference increases over time. And so these are years after recruitment, all randomized women. And these were women with a negative test at entry. The blue again, HPV screening, and the red cytology screening. And it's even bigger than before. That spread that rapidly increases after a while in the women that have received cytology compared to the lower line with HPV screening. So there's a value that we did not have with cytology, the higher, much higher negative predictive value of HPV testing. So over 8 years, HPV screening offers 60% to 70% greater protection versus cytology screening against invasive cervical cancer. Also, what is happening is the sharp decrease in lesions, high-grade disease of the cervix lesion are becoming much rarer than in the past, but still there's a lot of patients that are called having a lesion on the cytology, and they have to be colposcoped and to be biopsies for non-significant disease. We know that the positive predictive value will sharply decrease in the population that will have been vaccinated, especially for those that were vaccinated with the 9-valent vaccine compared to the 4-valent or the 2-valent vaccine. So the cost effectiveness of primary HPV cervical cancer screening is changing. So primary cytology, we look at the estimated 3-year cost of almost $5 million. Primary HPV, $3.5 million, and co-testing is also in the higher $5 million. So the economy that we make on primary HPV screening is substantial. So primary HPV costs less than primary cytology or co-testing, and the modeling studies that we have found that primary HPV more cost effective than either cytology or co-testing. And also it was predicted before we started having HPV vaccine available, it was predicted by colleagues in Quebec City that the economy that would be brought to the healthcare system would be changes in the screening program and not from necessarily the prevention of cervical cancer. There's a huge amount of money in the screening process compared to the money necessitated by treatment of cervical cancer. And the question is, why should we continue with the 20th century technology when we have 21st century technologies? So the reduction of HPV will lead to an urgency to change screening technology. Too many missed cases with cytology, too many cases to sort with cytology. The profits decrease, the risk increase, the risk on, especially after biopsy and all the treatment we do on the cervix, obstetrical complication and infertility issues, a sharp reduction of pressure on health resources, less colposcopy, less testing, and also the potential for self-testing with HPV testing. And a short view of the future of HPV testing. So self-sampling is now possible with HPV testing, and it's not at all possible with cytology. So number of countries already offering self-sampling. US FDA recently approved in clinic self-collection on an expensive dry swab, so it doesn't need a complicated technology or glass slides that can break in the transport to the lab. It has better performance than cytology, spares resources, spare even more resources when negative, because these women don't need to come back for triage strategy. And of course, for women, it's the most acceptable screening method. And to just give an overview of what's happening nowadays with cervical cancer, I will remind you of the Millennium Development Goal, where we invested a lot of money in reducing the pregnancy-related complication, reducing maternal mortality. So the annual death rate was 350,000 per year. And with the Millennium Development Goal, we had a sharp decrease of 34% between 1990 and 2008. It was prioritized in the Millennium Development Goal, and it cost about $12 billion US dollar. But in the same time, what happened with cervical cancer? 270,000 women were dying annually of cervical cancer. And during that period that we saw a reduction of 34% of the decline in mortality from cervical cancer, from maternal mortality, there was an uprise of 45% in the increase in mortality in women between 1990 and 2008. Now we have the Sustainable Development Goal, and it's not clear that it's precisely an objective of these goals. And we don't know yet how much it was cost, but certainly when we look at LMIC and the huge impact that young women dying from cervical have on the economy is huge. We know that in developing countries, 75% of agriculture revenue comes from the work of women. And also when these women die, they are younger and they have young children. And we know that young children with a mother that die usually don't continue going to school. And it's an highway for poverty for these kids. So if we go back to the cervical cancer screening principle, we see that what were boxed in yellow with cytology becomes in green. There should be a suitable test or examination, much more sensitivity. The test should be acceptable to the population because of self-sampling, and also that we're going to be doing less testing because of the high negative predictive value, and also the cost of case finding, including diagnosis and treatment, will be much lower. So what were three criteria that were yellow box are now in the green box with HPV testing. So elimination of cervical cancer is possible because we have the science, we have the tools, we have WHO objectives. We need your engagements now, small and big, at home and at work, in groups of your community, and one person at a time in your practice. And together we can achieve elimination of cervical cancer. So thank you for your attention. And I will now pass the control to Dr. Riedel that will talk about molecular diagnostics for HPV.
This was a great review, and as Dr. Steben mentioned, I will now talk a little bit more in detail about the diagnostic test methods. So these are my conflicts of interest disclosures on the slide. at large, the association or the serving as a speaker for Abbott Diagnostics, and most of my other research is actually related to antibiotic resistance. The objectives for my presentation include an overview of the Alinity M analyzer and the diagnostic assays and capabilities. I will also briefly address the possibilities and considerations for selecting and expanding laboratory test menus. In this context, thirdly, I will talk about benefits of in-house HPV testing versus send-out testing to a reference lab, and ultimately I will address again primary screening and HPV genotyping and the benefits of those technologies when deciding to actually bring in an assay in-house. So just briefly as a review, as mentioned by the previous speaker, there are more than 200 genotypes of human papillomavirus. This is a DNA virus that infects cutaneous and mucocutaneous cells. The virus is typically spread by direct skin-to-skin contact for those genotypes that cause cutaneous warts, and sexual contact, including vaginal, anal, and oral sexual contact for those genotypes that infect mucosal cells. These genotypes are stratified typically into the high-risk and the low-risk genotypes as listed here on this slide. Cervical cancer is a common malignant disease that is associated with a high morbidity and mortality in women worldwide. As the previous speaker mentioned, there are over 300,000 deaths in women directly attributed to cervical cancer alone. According to the CDC cervical cancer statistics, each year in the United States, there are about 11,000, a little more than 11,000 new cases of cervical cancer diagnosed and about 4,000 deaths related to cervical cancer. Although current US guidelines recommend HPV 16 and 18 genotyping as a triage in HPV positive women, testing for HPV 16 and 18 only fails to detect cervical lesions associated with other genotypes. Recent studies have shown that a large number of women with abnormal cervical cytology results, that includes the cervical intraepithelial neoplasia types 2 and 3, are attributed to high-risk HPV genotypes other than 16 and 18. And these studies also demonstrated that different genotypes have different longitudinal risks for cases of women with SIN2 positive lesions. Again, the Pap smear, as mentioned previously, a routine screening test long time used for cervical cancer, which was first reported in 1928, and its efficacy was proven by 1941, has been widely used to screen for cervical cancer, and since then it has been used worldwide really very successfully. But since the 1980s, when HPV was discovered to be playing a very significant role in cervical cancer, a lot of efforts were placed on developing molecular tests to detect HPV in cervical specimens. And after the first clinically available HPV tests were implemented in the 1990s, various improved diagnostic test platforms were developed, and subsequently, as we just heard, the testing guidelines were updated by many medical societies in the 2000s. Now, given the strong etiologic link between high-risk HPV infection and cervical cancer, a high-risk HPV testing is now being considered as the alternative for cytology-based cervical cancer screening. Many of the test systems have been developed that can detect a broad spectrum of HR genotypes by one assay. But for screening purposes, again, 16 and 18 were the main focused. Candidate high-risk HPV tests to be used for screening should reach an optimal balance between clinical sensitivity and specificity for detection of high-grade cervical intraepithelial neoplasia, as well as the cancer, to minimize redundant or excessive follow-up procedures for high-risk HPV-positive women without cervical lesions. For regulatory approval in the United States, the FDA follows a very rigorous evaluation process, while the conformity assessment applied in the European Community market for in vitro diagnostics, short the CE mark, IVD, process is less demanding than the FDA's procedure and largely technical. The most widely adopted and internationally accepted guidelines describing minimum requirements for high-risk HPV DNA tests, as I'm stating here, for primary cervical cancer screening were introduced in 2009 and provide guidance for the validation of new candidate assays. So again, here's on this slide, I want to show a brief timeline of the development of various HPV diagnostic test platforms and those that then offered ultimately a more extended genotyping. It is noteworthy to mention that many of the originally established and earlier molecular tests actually detected the genotype 16, 18, 45 only. The clinical performance characteristics for these early tests were actually fairly similar. I already mentioned the role of cervical cytology and the additional diagnostic tests, and I listed those again here. Those include cytology, colposcopy, histologic evaluations. But again, studies have demonstrated recently that HPV testing offers a better sensitivity for detecting cervical intraepithelial neoplasia and much better than the cytology-based screening tests alone. So at this point, I'd like to just take a quick look at today's microbiology laboratory and provide you with kind of an evolution of what happened with molecular tests. You know, when we talk about HPV diagnostics and molecular testing, we have to kind of consider this in the general context of how microbiology really changed in the past few decades. So there was a 40-year path of evolving molecular diagnostics from the earliest PCR methods. And of course, what was seen is that molecular tests have really, compared to a lot of the traditional microbiology tests, and in this case, cytology tests, a much better turnaround time, much faster. The idea that faster is better kind of was implemented in many thoughts of on the clinical side. Now, in microbiology, we have single limited target molecular tests, and I listed a few of those here on the left side. HPV can be applied as one of those. We also have syndromic molecular test panels and point-of-care molecular tests. Those were largely applied to acute infectious disease processes. At the same time, now we're implementing and expanding microbiology in the field of next-generation sequencing and develop more complex molecular analyzers and a laboratory automation, something that in chemistry we have taken for granted in clinical chemistry laboratories for a long time, but this is actually moving forward into the microbiology world as well. With that said, the clinical needs and expectations really heavily influence the decisions on laboratory testing methods and the selection of those newer methodologies to be implemented in clinical microbiology labs. Now, what should one consider when we're talking about selecting a test menu or expanding a test menu for that matter? So initially, there's probably the test purpose that needs to be defined. Why should we bring in testing? What is involved, what types of technologies, what are the qualifications of the technologists performing the test, who should be performing the test, and who are the patients on whom we perform the tests. So this is a very involved step. Of course, part of that is answering the question of available platforms, the pros and cons. We usually go to published studies. We're also looking at the regulatory approval. And then one must determine the test's optimal diagnostic accuracy and determine the diagnostic accuracy in practice. So that's what we call a validation and verification process prior to implementing a test clinically. And of course, once a test is clinically implemented in a laboratory, we also need to continue to monitor the test utilization in routine use. That includes performance characteristics and the clinical impact on patient care. So it seems intuitive here that we're looking at benefits as obviously streamlined operations and a more efficient workflow in the laboratory. We want to be cost effective, and we want to have the most up-to-date diagnostic methodologies in order to actually be in line and in offering the best and standard of care to our patients. When we're looking at analyzers, we are nowadays also looking at reduced reagent and supply wastage. So how frequently can one operate or offer the test? What are the complexities of reagent storage, of quality control runs, etc. So all of that together is really done to enhance clinical decision-making and improve the operational efficiency of a laboratory. So in this context, the molecular automation or laboratory automation that I briefly touched on the previous slide brings me to the Abbott Alinity M analyzer, which is a fully integrated and automated molecular diagnostics analyzer. It uses state-of-the-art ReadyFlex technology and delivers really a next level of flexibility in diagnostic testing, simply because, as stated on the slide, here on the left side, you see 20 onboard assays with a fairly short processing time for the particular runs, with a high throughput capacity, but also random access. And I've taken kind of a picture here on the right side of the analyzer in our laboratory that shows you how the automated robotic system actually moves smaller cassettes of 4 samples through the analyzer. So the random access allows, the ability to run smaller, I don't want to say batches necessarily, because batch testing implies that we'll run a large number of samples through the analyzer and are done for the day. But in this case, 4 samples, 2 samples, even a single sample can be run on this analyzer. QC is done once daily, and so the onboard capacity of various assays with reagent storage and the daily QC, which does not require repeated QC runs with every sample group that we're running through, really improves the high throughput and the readiness of diagnostic testing with this analyzer. So really reminds me a little bit more of what we do and have done in clinical chemistry laboratories. We're running QC in the morning, and then we're just on a regular process, just put samples on in the analyzers, proceed with the respectively required diagnostic testing. So with that said, again, it's a full automated analyzer. Again, a close-up view of the interior of this analyzer, displays on the panels, and the test menu, as you can see, goes from respiratory virus testing that includes COVID and flu and RSV, SARS-CoV-2 assays, CMV, EBV, all the way to HPV, sexual transmitted diseases, infections, chlamydia trachomatis, Neisseria gonorrhea, Trichomonas vaginalis, and Mycoplasma genitalium. So let's compare various molecular analyzers in this respect. And this international multi-center study actually compared the performance characteristics of various standard analyzers and various assays, including HIV, Hep C, hepatitis B, high-risk HPV, STI testing. And the study compared workflow between these different analyzers, from receipt to of samples to sample preparation and the analysis of the samples. And what was found is that the total turnaround time for the Alinity M was definitely significantly reduced compared to most of the other analyzers. So sample on board turnaround time for standard workflow using routine analyzers was anywhere from 7 to 32 hours roughly, compared to 2 to 6 hours for the Alinity M, and this was assay dependent. The processing turnaround time for the Alinity M for all of the assays was also significantly shorter compared to the other analyzers. So in summary, what this multi-center study found was that consolidated continuous random access workflow of the Alinity M analyzer really reduced turnaround time across various assays and was expected to improve both laboratory operational efficiency as well as the patient care by actually providing faster results to clinicians. So with that said, the HPV, high-risk HPV assay on the Alinity M is basically testing for various high-risk HPV types. Now, just to recap briefly, persistent infection with high-risk HPV causes virtually all cervical cancers, as the previously speaker mentioned in greater detail. Again, HPV genotypes 16 and 18 are linked to the vast majority of all cases worldwide, and there are now established gold standard guidelines for diagnosed screening, which include the Pap smear and the cytologic examination, but also the HPV diagnostic testing. So here's some additional information on and specifics on the Alinity M HPV assay itself. The assay has actually separate channels for 16 individual channels for 16, 18, and 45, and then reports other high-risk genotypes in 2 other channels for reporting. So the individual 31, 33, 52, 58, for example, are batched in one, and then channel 6 is the internal control. So the channel for the HPV 31, 33, 52, and 58, as well as together with the other genotypes, also covers the genotypes that are included in the non-valent HPV vaccine, the Gardasil 9, that is widely used. It avoids disruption of workflows. This assay in the complexities and screening guidelines for HPV and cervical cancer can be nicely addressed by using this assay that provides more detailed information on genotyping and specifically addresses the 3 most common genotypes. So these are the HPV diagnostics intended use guidelines for the Alinity M HPV assay, so to screen patients with ASCAS on cervical cytology to determine the need for referral to colposcopy. This assay can be used as a first-line primary screening test to identify women at increased risk for development of cervical cancer or presence of high-grade disease. It can be used as approved to assess the presence or absence of high-risk HPV genotypes 16, 18, including 45, to identify women at increased risk for the development of cervical cancer presence. And it can be used in conjunction with cytology to assist in various diagnostic approaches. So at this point, allow me to just talk a little bit about the experience in our laboratory. I'd like to actually go back to the time of COVID-19 when we implemented the Alinity M analyzer in our laboratory. We at that time needed an analyzer with a high throughput testing capability for SARS-CoV-2. We used the Alinity M as our main analyzer. At the time, like many other laboratories, we actually temporarily discontinued in-house testing for hepatitis B, C, HIV, and so forth, and sent those out to reference laboratories. The previous speaker actually referred to the effects of the pandemic on overall screening for HPV. and I don't want to go into the details of the effects of the pandemic, but a lot of those issues were related to the ability for high throughput testing, and therefore the need to reduce some of the other molecular diagnostic tests. There wasn't simply enough room on analyzers. We continued our STI testing on the Panther analyzer that we also had in our laboratory, and of course we expanded with a lot of other diagnostic tests and multiplex testing, as well as point of care testing for the pandemic. But as the pandemic subsided, and we at that point had our test platforms, the LNTMs, on board, we actually brought back a lot of the assays that we previously did in-house, and actually expanded our diagnostic testing as we moved forward. And while there's a continued need for COVID testing, and we see from time to time numbers increase and probably go down, in the winter we probably see another peak of the COVID tests, the analyzer itself, with its random access capabilities and the high throughput testing, the stability of the reagents on board, really allowed us to bring back the list of assays that are listed here on the right side to our laboratory and continued our testing. We're running basically the assays on 6 days a week at the moment. And the testing schedule that we're currently following is listed here. Now, at the present time, we are still outsourcing or sending out our HPV testing, which is at large done in conjunction with cytology at this point still. HPV testing is performed at our reference laboratory. And the assay they used is the Hologic Panther, which is a transcription-mediated assay, testing for the mRNA with E6 and 7 being detected, reported, and then a reflex on the first test positive result to genotyping for 16, 18, and 45. We have a fairly high test volume, and of course send-out testing, as I mentioned before, comes with an increased turnaround time. So for that matter, we decided to actually move forward with evaluating the HPV assay and bring this test in-house. Again, just to recap briefly, ASCUS, in ASCUS, approximately 50% of cases are associated with high-risk HPV infection, and cervical intraepithelial neoplasia indicates an active HPV infection, as previously mentioned. So there's definitely the benefits of screening tests, and again, historically, the Pap smear has been well established, but as we heard from our previous speaker, the HPV screening has also shown to clinically improve screening approaches, has increased sensitivity, specificity to screen for cervical cancer, and the benefits have been well established. That said, we heard the benefits of HPV vaccination that are well established, and the earlier diagnostic assays that look for genotype 16 and 18 have also been well documented in the literature. But I would want to make the case that other HPV genotypes also provide additional and very important information, considering the testing of HPV vaccinated populations to better understand the role of those other types of genotypes. Now, this study, for example, compared the various diagnostic test methods and platforms with earlier tests, the main groups and subgroups of commercial HPV tests available on the global market. We're looking here at the high-risk HPV DNA testing without genotyping, with genotyping that is restricted to 16, 18, 45, as well as those that provide extended genotyping, compared to those that are looking at the messenger RNA tests focusing on E6 and 7, and potentially then going back to the to genotyping as a reflex test, which then also increases turnaround time of results. In general, most of the FDA-cleared tests have fairly similar sensitivities and specificities. But we need to take a look at the additional information that the extended screening provides. And so in this regard, a fairly recently published study in the Journal of Clinical Microbiology did take a look at the extended screening and risk stratification. And what was important to realize here, that 1 out of 11 women positive for HPV 31, 33, 52, and 58, and 1 out of 40 women positive for the other high-risk genotypes will have underlying cervical intraepithelial neoplasia too, and therefore a significantly higher risk. So there are definitely benefits, and again, they stratified this the same type of groups with respect to cancer as well. And this study very clearly outlined that there are benefits and improved benefits of identifying the other high-risk genotypes in addition to 16 and 18 as well. So again, as I mentioned, considerations for test menu selection, there are benefits, streamlined operation, cost effectiveness, and to be up to date with our diagnostic methodologies to better serve and allow for better clinical decision making. And with that said, comparing in-house versus send-out testing is actually an important consideration, not only for turnaround time, but also for cost effectiveness, for control over specimens. So the errors previously mentioned, for example, for collection, processing, transportation, stability of specimens, significantly higher for send-out testing compared to in-house testing. The test order management, reduction of errors and inaccuracies, as well as customization and enhanced capabilities of expanded diagnostic testing certainly are benefits and things to consider. So faster turnaround for results has been shown in many studies to improve patient care. And all of the other benefits listed on the slide nicely outline why it is beneficial to bring certain diagnostic tests, and that includes HPV testing in-house. In addition, as I mentioned, the Alinity M analyzer has a larger group of diagnostic test menus on board, which includes STI diagnostics. We evaluated this, the STI diagnostic panel on the Alinity M as well, and published the results as shown here. We compared this assay to the Hologic Panther Optima assay. And again, what is shown in our study here is that the Alinity M STI assay has excellent clinical performance. The advantage to simultaneously detect all 4 targets for the STIs and may help to understand current gaps in STI epidemiology and surveillance. Why do I bring this up here in this context with HPV? Again, having an HPV assay and an STI assay, particularly with high risk sexually active patients, affords actually faster turnaround time and a more comprehensive diagnostic assessment in patients for both HPV testing as well as STI testing. So let's talk briefly about our validation. We actually did start validating the HPV assay in-house. It's currently in progress, near finalization. We follow FDA clinical guidelines. We're using the thin prep materials and have used so far in parallel testing with the currently established diagnostic HPV tests, more than 50 samples, and compared the results to the Hologic HPV assay that we have. So far, we've seen very excellent correlation of those results. And what I'd like to point out that we're at the present time still used a manual transfer method from the thin prep to the assay kit itself. In terms of the reporting, there are different approaches to the reporting. The package insert for the assay, for the HPV alinity M assay, lists reporting of individual positive and negatives. One could also take an approach, and this is what we plan on doing, is to look at reporting of 16, 18, 45 as an individual positive negative result. Obviously, the reference range is always negative, and then we will report the other two channels. So an individual channel reporting of results, which would be beneficial. Now, what are the advantages of random access molecular analyzers? As I mentioned before, the field of molecular diagnostics is rapidly expanding and evolving. Future directions for us will probably be affording same-day results reporting, Monday through Friday at least, testing of HPV. We will use the approved collection specimens, cervical types. We are currently considering both primary as well as the companion testing or reflex testing in patients for which there is an ASCUS diagnosis on cytology. And we are currently in the process of discussing with our clinical teams changes to the approach to HPV testing in conjunction with updates in national and international guidelines. The advantages definitely show that we will have at that point a same-day reporting for HPV results, which will, we hope, significantly improve clinical patient care management. We have high numbers of HPV test results that we anticipate in terms of processing, and we will have to work on our integration of the test results reporting in our LIS system with the pathology, cytology reports as well. I'd like to briefly kind of summarize here the HPV diagnostics on the alinity M. Again, the assay provides an integrated risk stratification by separate reporting of the three most common genotypes, as well as two pools of the high-risk genotypes. It's one single reaction, and therefore one result coming out with these, technically speaking, 5 different results individually, 16, 18, 45, and then the two pools. But again, from an assay perspective, this is a single test reaction. Multiplex testing for 14 high risk with for both general patient populations as those who have received an HPV vaccine will hopefully further improve clinical care. And the built-in cellular control is there to assure the sample adequacy at the same time, no separate testing required. The previous speaker mentioned that self-sampling for HPV testing is now something that that also will improve HPV diagnostics. Several countries already offer self-sampling, and they are listed here on the slide. And very recently, the FDA approved in-clinic self-collection kits here in the United States. Certainly, the advantages of self-collection are intuitive with less painful processes, more comfortable. We hope a broader patient acceptability, time saving. There may be disadvantages to some extent. So what are the quality and the adequacy of samples in self-collection? Again, with clinic self-collection, this should probably be able to be addressed appropriately. If one were to move to home collection kits ultimately, the mail-in versus clinic drop-off and the transport of samples to the laboratory may be issues that would need to be addressed. But again, the self-collection hopefully increases a broader and wider acceptability of primary HPV screening in patients at risk. Now, I want to conclude here with some remarks on future directions on HPV testing. So we're definitely seeing a shift from cytology alone, the pap smear, which itself is still a good test. But again, for screening for cervical cancer, HPV testing has certainly shown the higher sensitivity and specificity. With those newer technologies for HPV detection, risk assessment for cervical intraepithelial neoplasias has significantly improved and will continue to improve. Random access and multiplex molecular diagnostic test platforms afford laboratories better processing of samples, more frequent testing, and more timely reporting of results. And that in the context of HPV really means that the extended testing of genotypes beyond HPV 16, 18, and 45 will further improve the detection and risk assessment and management of patients with cervical intraepithelial neoplasias and at risk for developing cervical cancer. And again, very exciting, the implementation of HPV self-collection of self-sampling kits could further improve uptake in cervical cancer screening, especially amongst hard-to-reach populations. With that, I conclude my portion of the talk. I'd like to thank you for the attention, and I'd like to thank Albert and for the opportunity to present here today.
Wonderful. Thank you, Dr. Steben and Dr. Riedel, for your informative presentations. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen. We'll answer as many questions as we have time for. So our first question asks, I believe this is for you, Dr. Steben, as a provider that transitioned from co-testing to HPV primary screening, what were the biggest obstacles to the transition?
I think there are a few obstacles, like all the changes that occurs with the interaction between the practitioner and the lab, the paperwork and the follow-up, the filing. So this is a little bit out of our control. There are issues in Australia. They had a big failure of the introduction of HPV testing because they failed to educate women. Women were seeing HPV testing as a cut in women's health. Not too far ago, we were going for yearly pap smear, then we went to 3 years, and now we're going to 5 years. So a lot of women were boycotting HPV testing. They wanted to stay with the 3-year period for cytology. So there's a need for education to say that this test is powerful in terms of negative predictive value, and we can spread the presence needed to do tests. And also, women will go on the internet, HPV DNA testing, HPV testing, they'll see it's an STI. And someone will say, well, I'm not at risk, I'm not sexually active, or I have a steady partner for so many years. So there might be a need also to educate that this is a test for prevention of cancer and not a test to catch unfaithful partners.
Okay, wonderful. Thank you. Our next question here is for you, Dr. Riedel. Your lab has both a Hologic Panther and Alinity M platform. Which were some of the reasons that you decided to put the HPV assay on the Alinity M system?
Excellent question. I think, as I mentioned in my presentation, the Hologic platform as a limited assay availability is a lot more hands-on in terms of sample processing compared to the Alinity M, which has some 20 assays total that could be included. Now, another concept here, and I think looking at what is actually reported, one should consider if we are looking at HPV positive detection using the mRNA E67 assay on the Hologic, we're not really reporting instantly genotypes, and reflex testing would then have to be performed, which increases turnaround time, a lot more hands-on processes. Looking at the ability to, in one assay, to detect and report the genotype 16, 18, 45, and then additional 2 pools of high-risk genotypes is time-saving, so to speak, right? And it's offering a more comprehensive assessment compared to the other analyzer. So to us, it made more sense considering the changes in the guidelines and testing and reporting guidelines, and the studies that show the importance of the reporting of other genotypes as well.
Excellent, thank you. Our next question here, and I know that we are out of time, so I'm going to just squeeze a couple more in here just in case. Our next question for you, Dr. Steben, you mentioned that more women screened by cytology will have to be referred to colposcopy and biopsied for non-significant disease. Could you elaborate, as that may be counterintuitive to our listeners? Other than impact of vaccination, what else may contribute to this observation?
What was seen in laboratories is that the brain of the cytologist is skewed toward a certain percentage of abnormal result. And with HPV vaccination, we know that these lesions will be less and less associated with high-risk HPV, but still, there's overcall of the lower significance lesion on the cervix. So HPV testing, it's a machine. It doesn't make a difference between I'm tired, I'm not tired, and I've seen so many cases. It will be positive or negative. The cytology brain, especially at the beginning, the first few months, might overcall a lot of the benign lesions.
Okay, great. And then our last question here we'll slip in is for you, Dr. Riedel. What are some of the considerations that a lab should keep in mind as they bring in testing or switch from co-testing to primary screening?
Again, an excellent question, and Dr. Steben, my colleague, commented a little bit on the problems that occur in other countries as well. So the considerations are, number one, related to very simple logistical issues of the IT system and the reporting format. So an integration of a test result with existing cytology. But I think it's at large related to the education of providers on both side pathology, so cytology, pathologists, as well as the clinicians. And thinking about talking to the colleagues in the OBGYN department of, how do we want to change the approach to diagnostic testing. Certainly evidence is out there, but I would predict that such a process involves a lot of discussions questions on how do we integrate our reporting on the clinical side, clinical laboratory side versus anatomic pathology. How are results, if there's co-testing, for example, are they intuitive to understand? So I think I would encourage laboratories really to early on, if you consider bringing on an HPV assay and considering the changes in guidelines, I would encourage the laboratory to initially start talking to the clinical teams and see how they want to change approaches to diagnostics and to actually utilize the enhanced capabilities that the lab now offers. So I don't like to operate in silos. So from my perspective, it's very important to take this approach in conjunction with the clinical colleagues. So lab results that are reported in a way should make sense in the greater clinical context.
Excellent, thank you. I want to thank you both for your time today and your important research. We would also like to thank LabRoots and our sponsor Abbott for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and any submitted during the on-demand period will be addressed by our speakers via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone. Goodbye.